We are officially live, so we can get started. So welcome,
Great.
Dr. Atwal. Thanks for joining us. Thanks for working with me for the first time. Before you even opened your clinic, I was aware of it and I was following it because I've worked in this EDS and worked the EDR community for probably 15 years now, since I was diagnosed, helping, and then I founded EDS Wellness. And there was nobody in Florida that I could refer people to, and we have a lot of family there. And I've always wanted to move to Florida, but that was one of my biggest fears. So when I saw that you were opening a clinic, I was so excited. Yeah, so I followed it, and then was just so excited to see how things have gone. And then I heard your podcast with Dr. Bluestein, who's on our board of directors, and I work very closely with her. She's awesome. Yeah, so I'm just very grateful and excited to have you here. So for those that don't know, before I introduce Dr. Paldeep Atwal, I am Kendra Neilsen Myles. I am the executive director and founder of EDS Wellness. And we are doing, I've done webinars for several years, but I hadn't done any this year. I've been focusing on teaching yoga online, but a combination of continuing the webinar education series, wanting to work with providers like Dr. Atwal, and also helping support the online support group part of the local EDS, Metro EDS DC group is why we're here now. So I'm excited to continue this. So this is a webinar format versus a group format. So that means that those that are attending on Zoom have registered. They don't have their videos or mics on. They can still participate in the chat. So for those that are on Facebook, they can also participate underneath the live feed. But we'll first just go ahead and get started with, it's a casual, we don't have a presentation planned. Dr. Atwal is pretty much going to talk about his experience, and we're going to learn about him and why he moved to Florida and started his clinic, and how he found the 14th type of EDS, which I'm very excited about. So for those that don't know, Dr. Atwal, I just had your bio up for just a minute and I lost it, of course. It was right here. Oh, here it is. So Dr. Atwal has founded the Atwal Clinic in Jacksonville, Florida, but you also just are opening another office, if I'm not mistaken, in
Palm Beach.
Oh, is that right?
Palm Beach, yeah, Palm Beach, Florida. So South Florida, one in North Florida, one in South Florida now. So, yeah. That's
awesome. And you see patients for genetic consultations in person and online through telemedicine. I didn't realize that you did a lot of the telemedicine, so that's awesome.
A lot. Yeah.
You're very well known in the ED. Dr. Atwal is very well known in the EDS community. He's helped discover 2 new genetic connective tissue disorders resulting from defects in the FLNA and AEBPI genes, and provides genetic consultations via telemedicine or in person for many with connective tissue disorders and other rare diseases. Dr. Atwal has also more than 60 publications on human genetics to date. That's awesome and fascinating. And if I'm not mistaken, you are your specialty in genetics is more specific. Can you talk a little bit about that?
Yeah. So as you said, I trained in internal medicine or adult medicine before genetics. I think that's one of the reasons I'm comfortable seeing adults a lot. I know a lot of geneticists are it's hard to get in because they don't like seeing many adults. And then after that, I did my medical genetics fellowship training at Stanford. And then I did as you said, I did a subspecialty biochemical genetics fellowship at Baylor College of Medicine in Houston, which is looking at metabolic defects or metabolism problems, things that happen in kids, mitochondrial diseases that happen in adults and kids, and related conditions. So anything involving energy or metabolism, it's in that specific subspecialty. And because it deals with a lot of enzymes and pathways and that kind of thing, you kind of need a little bit of extra training for that. Did you want to hear about how I got involved in?
Yeah, I was going to ask. I would imagine that specialty of medicine is actually changing quite a bit and evolving.
Yeah.
And which is just fascinating to me. But how did you go from what you were doing to starting your EDS clinic or the research that you did?
Yeah, so when I was at training, you mentioned the FLNA condition. I had a patient, a very interesting patient, and he clearly had some connective tissue disorder, genetic disorder of connective tissue, but it wasn't one of the ones that you would, it wasn't Marfan, it wasn't Ehlers-Danlos, it was something else. So we did an exome sequence on him, found an interesting variant, and I did a lot of extra work, sequenced other family members, found a few other things, and eventually published that as a new syndrome. He had a very really specific syndrome. We actually found another group that found another family with it, so that made it easier for us. It's hard when you've only have one patient.
And that wasn't under the EDS umbrella.
That was different. It's not a subtype of EDS. And then, so fast forward many years after that, when I was at Mayo. So after my training, I went to Mayo Clinic, and that's why we moved to Jacksonville, Florida. And I was a medical director of this individualized medicine clinic. This kind of ideas, this kind of cutting edge medicine, genomics, and all of the other kind of personalized and individualized medicine that you can do now. And Mayo was very invested in it at the time, still is. So I was leading that in Jacksonville in the clinic, and I had another patient he had EDS. No, he had EDS, but it wasn't hypermobile, and it wasn't the other types. It wasn't classical. It wasn't, but it fit the kind of classical spectrum, but it wasn't classical EDS. So again, did exome sequencing on him, found out that what he had, and had a collaborator that had an animal model or mouse model in Boston, and a few other collaborators around the country, and we ended up publishing this really big paper on this new subtype. And we had another EDS doc, Claire Francomono, involved in it as well, and another Nasli McDonald, another EDS doc. She's in, you probably, they're in your area, right? Or they were.
Oh yeah, I'm very familiar. I haven't worked with her, but I worked very closely with Dr. Francomono.
Okay, great. Yeah, so both great docs. So we had them involved as well. So it was a really nice paper, and I went to just last year I went to EDS conference. There was an EDS conference in Japan, and I presented on that. And there's been a lot more patients found with that subtype. It's not very common, it's very rare, obviously, but we found a couple of patients, and then now there's like a dozen patients with it. So just very quickly, within a year or two, we just find, now that people know it's there and are finding it, are looking for it, then you'll find more. So that's kind of how these things work, and it's great that happens.
Well, truth be told, I've always joked with Dr. Francomono that there's going to be a type called the Kendra type of EDS, because we still never identified it. And it's great. My family is very interesting on both sides, and very clear. As a kid, I don't know, still classical EDS, but I was negative for the collagen 5 mutation. So who knows? I always joke it's going to be the Kendra, the number 15 type. But my family, it's very interesting. So so then you have your clinic, and you started your clinic in Jacksonville. Is it, do you see people in person, or did you just mostly start telemedicine?
Both. And I knew telemedicine, well, this is in 2018, start of 2018. I knew telemedicine was clearly going to be a big part of the future of medicine. It was going to be not just, it'll just be called medicine. It won't be like a different thing where all the doctors on video this time. It'll be normal. Well, I wasn't expecting COVID, obviously, and now it's really made it normal. I mean, everyone's doing telemedicine now, but when I started that, I really wanted telemedicine to be a big part of it. So I offered telemedicine appointments to people from the start, and it used to be about 50-50. 50% of people would want to do telemedicine, 50 would want to come in person, and I just let people decide wherever they're comfortable with. And some people, they like being seen in person. They don't mind the travel, or they like the travel for another reason. And with some people, they can't travel, or it's added expense that they don't want, and so many reasons. So we're hard enough to find as it is. So offering more ways to get to be seen, I think really helps the people get access.
Is that hard? Because I totally agree with you. And in fact, when I was doing the business plan for EDS Wellness, actually going to 501c3, that was, I was coming from a public health and health education background, but I also believed very much like you did that I wanted to be virtual. And so it's not as easy, it wasn't easy as it is now, but I did way too much research into it. But I also really believed that that was where things were going to go, and also how I wanted to reach people. But was that challenging to see people from a genetic condition via telemedicine?
I did have some apprehension at the start, and I was worried that we couldn't do things that you'd normally do, or be able to see things, or touch, get the sense of the skin texture and those kind of things. That and so, but having done it for years, I don't really think there's. I don't say there's not anything, but from what I've seen, you can see anyone over telemedicine and any part of genetics, and get them what they need. I think that's the key point. It might not be perfect, but it will be. It will get them. You can also follow up with things. If you can't see something, you can ask them, okay, do this, or get a local doc to do that and send it to me, or give me a picture of this, or so it's not. You have to get a little bit creative, but you can get everything you need.
Yeah, you have to be willing to do it. Yeah, do the work. Yeah. But I mean, what an amazing service to so many patients, including like my aunt who's in Naples and who can't drive to see you. So I mean, like, how awesome is it that you forged? I mean, it's just awesome, and it's so, I'm sure, so appreciative.
Yeah, and I just put other good things that other people have already thought about together, telemedicine and the practice model and a few other things. I just kind of combined what other people have already done. So I don't want to take too much credit for any of that.
No, but you were just willing to do it and then like put the work in to like figure it out, which I can totally understand. I mean, and the service it provides to patients is, I mean, it's amazing. Like you said, a lot of them can't travel. So if people want to get involved in research, are you still doing that? How do patients get involved if they want to be a part of, helping find the hypermobile gene, or the new type, or the another type of connective tissue disorder?
Well, it's a really important question. So I'll address it in a couple of different ways. Just in general first, and then I'll get specific. You asked about if I'm doing any research. So in general, they're being open to being involved in research is the first part. And the idea with research is you don't know whether it's beneficial or not. So you run a trial, or you collect data and then analyze it after a certain point to see if you can get any useful information for that. That ideally translates into better clinical care long term. Now, there's many different ways to do that. There's a registry where people enter their symptoms or their
Did I lose your video? Okay.
Oh, sorry. Are you back?
That's okay. I can still hear you. We can still hear you.
Yeah, people enter their. You can see me again, or you can see me now, or?
Yeah, I can see you. Yeah, and we can hear you. Yeah, at least I can. So you can continue.
Okay. Yeah, people enter their symptoms, or they get their symptoms history taken over a period of few years, or and see what happens. There's obviously the drug trials that people can, if there are any, that you can be part of, and also other efforts like trying to find the gene. So there's a study being run right now to look at trying to find the gene for hypermobile EDS, for example, and other studies as well. Clinicaltrials.gov is a good place to look. Any trial run in the US should be registered on clinicaltrials.gov. So if you go on clinicaltrials.gov, enter Ehlers-Danlos syndrome and see what's going on, and it'll tell you, are they active? Are they not active? Are they recruiting? Are they not recruiting? So it's a really easy resource that anyone can find in 2 minutes. You can see every single clinical trial in the US on Ehlers-Danlos. And so if you click on it, read about it, and then there's always contact information there on of the people who are running the trial. Email, phone, email them, call them. I mean, that really does work. And so that's one way. And just to make it clear, it's very important for real people to be involved in research. You can't make any meaningful statements if real people aren't involved or real patients aren't involved, because it doesn't. You're not looking at reality then, right? It's the real patients are all that matters, right? Ultimately, so then what am I doing? So I'm continuing to, on a patient by patient basis. So sometimes you see someone that really does have something different, and I'll take that on and try and find the underlying cause through a variety of different clinical and research methods and collaborators that I have in basic science and protein modeling and other areas. We also are trying to start our own kind of research database long term, where we can collect data information on people long term to see, like, so if you look right now, for example, what's the most common joint that subluxes in EDS and hypermobile EDS, or what's the most common joint that has pain? Well, we don't actually know, right? People
guess maybe knees, but who knows?
That's a good guess. Hips are a good guess. Shoulders are a good guess. But
yeah, I mean, it could also be genes, the joints that we don't really think about, like TMJ or
exactly. That's a great, yeah. So there's a lot of basics that we're still actually don't know that well. And so having a group of well, the more the better. But if you have enough critical mass of information on patients, you can say, well, these are clearly the worst joints, and maybe orthotics or new developments should be focused on these joints first. And you can kind of guide therapies or guide guidance, even guide your guidance based on what are the worst things that people report. What about POTS? What percentage of people with hypermobile EDS have POTS? What percentage have mast cell issues? We know that there is a big percentage, but is it half? Is it 3/4? Is it a third? It's not. There are some papers out there showing this data, and they are very useful, but it's not. There's not actually. There's much less than you'd imagine.
Yeah, probably not enough to really make a really good educated, because we're still learning so much about EDS.
Yes.
And I was going to say, like, I mean, how many more types of EDS are there, or other conditions that maybe will not fall under the EDS umbrella, but are a different condition?
Yes.
It's just, it's so evolving, and it's fascinating. And I love, patients always want to know how to get involved in research. I know that there's, very many people that would love to donate their DNA, but can you talk a little bit about, probably two questions. They might be, they're kind of involved, but maybe we can kind of make it basic. So if there's more genomic research being done, can you explain the difference between exome and genome sequencing? And then my second question was going to be acquired versus heritable in terms of EDS genetics, as we're looking for it. Two questions, trying to keep them like they're important.
No, they are very important, and they're fairly straightforward. So I can deal with two for one when they're like that. So all right, exome and genome. What's the difference? One is a part of the other. So exome is a part of the genome. So if you get a genome, you get all of the exome. Now, got it. So exome is the parts of DNA that make proteins. And the idea behind, well, why is that part important? It's only about 1 to 2% of of your DNA. But that 1 to 2%, because it makes the proteins, it's a there's a very high likelihood of what we call pathogenic or disease-causing DNA changes are present in that part, as opposed to the other parts, the other kind of 99%, if you will. So that 1% has let's say between 80 to 90% of all disease-causing variants. So it's a really, really great place to look for those disease-causing variants, because if 80 to 90% are in that 1%, well, that's a natural place you would want to start. So when sequencing has evolved very rapidly in the last few years, over the last 5 to 10 years, certainly.
Oh, yeah, absolutely.
It was very hard to sequence 2 genes at a time, not too long ago. And
yeah, I mean, I had the Ambry Labs test. That was 21 genes. There was no, we couldn't even do it then. No genes.
Right. And now that average panel has 50 to 100, and then exome came out. Okay, rather than looking at 300-400 genes, let's just look at the whole exome. And now we're slowly starting to see genome sequence. Still, there's always a struggle with insurance coverage for these new tests. Genome sequencing is right in that, well, insurance isn't really covering it. 1 or 2 insurances are, but it's hard to get covered. So the next few years, I think we will see the shift towards genome rather than exome. Genome will kind of replace exome, but that certainly hasn't happened yet. I hope that answered the question. And then acquired. So Ehlers-Danlos is a genetic condition, meaning that something you're born with. So there is a genetic difference that causes the condition that you're born with. It's not something you acquire. However, there are things that can happen to you in your life that can make it present more, or present or manifest, if that makes sense. An acquired condition is something that due to other factors like environmental factors, lifestyle factors,
epigenetics, right? Epigenetic changes.
So epigenetics influences your risk of acquiring these conditions. So let's just talk about epigenetics since you mentioned it. So the word epi, right? So I don't know if you.
Now this is all good. Yeah. I think this is really helpful to help people understand.
Epi comes from the Greek word mean above. So epigenetics is something that sits above genetics to control that genetics. So epigenetics is basically a form of gene expression. Epigenetics is a way to control gene expression. So as you can imagine, when you're 5 years old and your bones are growing, you're growing rapidly, your epigenetic profile is different to when you're 50 years old. You're not growing, right? At that age, for example, or when you're in the womb, your epigenetic profile is different. Yeah, right, yeah, you're okay.
It's apparently shrinking.
right. And how does it do that? It does that through a process called methylation. Basically, adding a methyl group to a DNA molecule and stopping it from being seen by the enzymes that turn the DNA into RNA and protein, etc. So it's a way to control gene expression. Epigenetics is influenced by your environment. I think that's probably what you were talking about. So if you eat certain foods or do certain exercises or have certain stress factors, or that all influences your epigenetic profile, and hence influences which genes are being switched on and off.
And it can definitely make your presentation of symptoms and
of course.
Severity with EDS absolutely so much worse.
Absolutely.
So when you are seeing patients, do you regularly go to sequencing at this point now, or are there other tests that you do? And along that same line, what about those with hypermobile EDS? Is it worth getting tested?
So I to answer the first question, I regularly do offer genetic testing for in EDS and other conditions people present with. when it comes to hypermobile EDS, there's no gene for the hypermobile type. So the purpose of any genetic testing is to exclude or rule out other types of Ehlers-Danlos loss or other genetic disorders of connective tissue, including vascular fragility type genes. Usually, what we'll do is we'll look at the patient's personal history and family history, look for any red flags that would be indicative of one of these other types. If, for example, if there's a first degree relative that had an aneurysm young, or they have a personal history, or some other unusual feature, then we'll discuss that with the patient and say it's low risk, but some people are very, they go online, they read about vascular EDS, and they get very worried, and for good reason. And even if the risk is very, very low, they want to do the testing to even just for that extra bit of reassurance. And I think there's a personal utility in doing that. And so I don't want to stand in the way of people if they're going to be up at night wondering if they have, even though you told them like this is really really extremely unlikely, and you meet all the criteria for the hypermobile type, they're always still wondering. So if someone's in that situation, then I'm happy to facilitate the testing so they can see it's negative.
I think that it would be in the due diligence of medicine and healthcare to kind of rule out anything really serious anyway.
Absolutely, absolutely, I agree. And that's
I wish
the way
that's the way things were, right?
Yeah. That's the way I feel. For the ease of genetic testing, I mean, you can get the panel done for $250, $250 to $350 now, so it's still a fair amount of money for most people, but it's not $2,000, right? And so and your insurance usually covers it. So often people are paying, if they're not really paying much out of pocket at all for the actual test itself if their insurance covers it. But many people choose the cash option because it's easy and convenient.
Yeah. And it's amazing amount of people that are still not genetically tested when they have like a stroke doing yoga at 40 years old. And
it's scary. It's scary.
I still, for the life of me, and I won't name names, but I had an acquaintance that happened to, and it just baffles me that it's still in this day and age that even that situation, even with medical history that's questionable, that genetic testing is just not done it was totally dismissed. We have a long way to go.
I agree, and I think part of it is a lack of awareness in the medical community. I see it all the time. Medical genetics has come so far in such a short time. The average doctor that is not specialized in genetics has no idea what's available, and even knowing how to order genetic testing is not something they're able to do. And more than that, knowing that it's available is not something they're even aware of. So it's hard to recommend something that you don't know exists, if that makes sense. So that it can be problematic. There's a long way to go for it. I haven't quite figured out how we're going to bring the medical profession up to where it needs to be on genetic knowledge, but if you can figure that out, then I think if we can figure that out, then I think we'll done a great thing.
Dr. Atwal, I like doing these things, but I've had my fair share of having to go to bat and fight for my mom to get testing for amyloidosis, when she was still alive, and the pushback that we got, and the lack of resources even just here in the DC area for just Congo red stain testing was shocking. To be honest.
Just imagine, if you're talking about lack of resources and the capital, capital of the,
DC. I mean, it was like
richest country.
We had to fight for it. One hospital, right? And she still had to go be treated at Mayo Clinic in Rochester, which is a wonderful place. But I mean, so I totally understand. I don't know what the answer is going to be, but I have to believe that doing things like this, the work that you're doing, and the work that other providers that we're so lucky to have on our side are doing, is it's changing. I mean, things are changing. Clearly, the healthcare paradigm is shifting for so many reasons. There's a lot of clear issues that we need and need to fully understand more than just, you know, even just to like how we build our societies, and people aren't moving as much as they used to, and all these things that I'm fascinated with. So somebody actually sent a question. I'm looking at the time. Somebody sent a really good question via email, and I am going to ask it. I did ask another question. So are you okay taking a couple of questions?
Yeah, go ahead. Yeah, let's go ahead. Yeah.
It's I'm just trying to keep on my time schedule. It's 7:36. So how are you doing on time?
Yeah, no, I'm fine.
Okay. So is there any further research while I'm looking up this other question that you can share maybe into what's the latest on hypermobile EDS and HSD and kind of where we are right now? Is there anything that is happening?
Yes. It's an evolving topic, shall we say, but you know, the way I think what's gaining the most traction, and there's good evidence to support this, that if you think of this spectrum of joint hypermobility spectrum disorders, that's a kind of umbrella term.
Yeah,
and
sure.
The biggest part of the spectrum is benign joint hypermobility. So you're flexible, you've got positive biting, but you don't have the pain, you don't have any of the dysautonomic features, you don't have all of that.
But we're not using that term anymore. Is that correct? So what was the old? Is that correct?
Which term? Sorry.
The B9. Because there's also confusion with the verbiage, and I think it's confusing for patients too to understand.
Exactly. So the term benign by definition means it doesn't cause problems. But to your point, joint hypermobility actually can cause problems even though there's no pain. So it can cause other things. So I think the better term, and I'm just kind of giving the historic, perspective, but to your,
I like that. It's good. It's a big pendulum swing.
Your point is valid in that words do matter. So if you think about the largest part just being joint hypermobility syndrome, so you have a positive biting, but you don't have the pain and everything. When you have the pain and the dysautonomia and other features, kind of moves into this hypermobile Ehlers-Danlos part of that spectrum. That's kind of where a lot of the literature is right now. I'm not saying that's where it's going to end up, and I think the more research is done, the more we need to figure out. And then part of that also comes back to, well, why is it the only type we haven't found the gene, and why do you get these kind of severe dysautonomic issues, GI motility, POTS type symptoms? Why do some people also have these histaminergic sensitivities driven by mast cell issues, right? So and is it all unified? There's this is it unified in that the excess histamine is interfering in the collagen cross-linking, causing hypermobility? So is it actually so there's just to be
maybe
clear,
another component of the connective tissue? Maybe another component of the connective tissue causing issues.
Yes, and just to be clear, before I say this, this is that's not what I think or for sure or anything, but it's certainly a theory, is that hypermobile EDS is actually what's called a phenocopy of EDS, in that it looks just like EDS, but it's actually the underlying cause is something different to the inbuilt difference in collagen. So it's actually perhaps even the histamine issues that are causing it. So again, the point is a lot more needs to be done to figure this out.
Sure.
And well, it goes back to
I know that you're not the first person that has actually proposed that during a webinar. I think there's a lot that we have.
And it goes back to, why have we not found the gene, right? We know this is a dominant condition that runs in families. So it's clearly genetic, but there's no single gene. So all of the other conditions are what we call Mendelian. Sorry, I'm gonna. You can stop me if you want, but all of the
go ahead, please do.
Are Mendelian in that there's a single gene, single gene that if you have a problem in that gene, that causes a condition. So Mendelian, after Gregor Mendel, Mendelian genetics, you know, the P guy that figured out the different different properties of peas and how they can pass through generations. Now, so the question then is, well, is this Mendelian, or is it actually not Mendelian? Is it polygenic? Is there multiple different genes that, when they come together in a certain way, there's this threshold of, okay, well, they're all this type, so you're going to have hypermobile EDS, or because only some are this type and some are this type, you don't have it, or you just have the joint hypermobility, or you don't have any of it at all. So that's another
right.
possibility.
It doesn't end up being syndromic.
Yes, yeah, and then is it actually a genetic change that we can't detect reliably through current sequencing methods? So there are actually holes in the way we our current sequencing methods, and that we're not able to detect certain types of DNA changes very well, namely large structural rearrangements and kind of certain sizes of DNA deletions. So again, I can get very technical. I don't want to get technical, but the point is that there are some reasons that there are some things that need to be answered when it comes to
right. That maybe are the reason why we haven't found something just yet.
Yes, exactly.
And it's far more complicated than we would like to believe or want to believe, for sure.
You know, the more you know about it, the more you realize, oh, I don't really know that much. You know?
Yeah, right. I totally agree.
Yeah.
I totally agree. And I think it's complicated. It's hard for patients who are searching for an understanding. I mean, shoot, I would like to know too, but I've just, you know, there's clearly things there, and it doesn't mean that what we're feeling or experiencing isn't real. It's just not fully understood yet. I mean, you mentioned a couple of other comorbid conditions, but I also think about like chronic fatigue syndrome and other conditions that, you know, it's very peculiar to me that there seems to be subsets of patients that kind of have, like you said, kind of come with in certain sets, you know, like there's not a whole lot of people that I know that have my eye issues from genetics or my skin or the same profile that I have, you know, but there are a few. So why is it that certain things kind of go in certain ways when they clearly fit a you know, the picture? It's just fascinating. I think there's so much we don't really know yet.
You're absolutely right.
I would love to find, I don't think it's going to change anything I do. I'm just more curious, you know,
yeah,
know why I got the short stick in my family.
It all starts with curiosity.
My sister called me a lemon my whole life.
Yeah, it all start. I was going to say it all starts with curiosity. Curiosity is very, very important. So keep don't lose that.
So somebody was asking, speaking from going from genetics and like diagnosis to care, are there other options if you are already diagnosed with EDS and POTS?
Yes.
And you're looking for alternative treatments. Are there other things other than physical therapy, such as maybe oxygen treatment therapy or hyperbaric? I mean, is there any other alternative treatments that you are aware of?
Yeah, it's a good question. So what I look for in any treatment is evidence to show there's a robust improvement in the patient's outcome, and it has been repeated under appropriate conditions in many patients. So it's not, so basically it's not you know, someone felt a little bit better and so they recommend it for everyone else. So that anecdote, right? So unfortunately, and this goes back to our first question on research, one of the first questions on research is there's not really that many, there's not really that much being, there's a lot that we still need to do on the research in these good controlled trials. So randomized clinical trial, placebo or natural history controlled trials. Things like hyperbaric oxygen, that kind of stuff. There's really no good evidence base to support these things. It's not something I recommend in my clinic. I'm not saying you know, someone might not feel transiently better with it, but there's no evidence to show that long term there's a clear difference in people who do that and don't do that in hypermobile EDS, and that's what matters, right? For a doctor, you can't recommend something that you don't know is really going to be a benefit, right? It's unethical, right? So you have to really know yourself it's right, there's a benefit before you can recommend it to someone.
Right. Well, and there have been studies with that and certain other conditions. We just we don't have that yet. For so many things that we would all like to study for us, right?
Yes, yeah, and so there is you know, so the other thing I'll just say is, you know, physical therapy isn't all in the same. So there's seeing a physical therapist who's never heard of hypermobility Ehlers-Danlos, or never seen a patient, and then there's a physical therapist who all they do is treat Ehlers-Danlos, hypermobile EDS, and they might even have it themselves. Actually, I know a few that are in that situation.
For sure.
Now that is the type of person you want to be seeing, someone who is extremely knowledgeable. It's a very different experience, a very different outcome in general, compared to you know, regular physical therapy. Regular physical therapy isn't really designed for hypermobile EDS, and it's often it can even be problematic. So I would also make the point that, you know, the type and who you're seeing in physical therapy, their background knowledge and what they're offering is more important than even the fact that you're doing physical therapy.
Yeah, and their physical therapists also specialize and are educated differently too. You know, some integrate more breathing, and you know, some do pelvic floor physical therapy. So I love physical therapists, and I think that they all bring to the gift. They have knowledge. I mean, a lot of them have different educational backgrounds and different ways that they approach physical therapy. And
there's other things that you can do with that, like Pilates and even like pool type therapies, and you're not just straight kind of physical therapy as well. And then even people can do stuff at home with a recumbent bike or other stability type exercises. And so you're not once you get into it, there's a whole host of things that people can do. Also optimizing the other comorbid things like the POTS, like the, you know, people having GI motility stuff, getting that sorted out, like the mast cell stuff, getting that sorted out. It all affects, it all kind of affects each other, if that makes sense. So yeah, it's important to address it all to get this kind of global improvement. The good thing is, improving one generally has a small benefit on the others, so you can have this really strong compound effect if you try and tackle, you know, the kind of, let's say, the 2 or 3 big things. Helping all of them will helping one of them will help all of them, and so forth, and so on.
Right. I also feel really strongly about that. We can't be dependent upon always being able to go to the PT or a provider.
Exactly.
Sometimes money is short. Sometimes you don't have help. So what are you going to do when you have nothing and you're at the bottom of the barrel? And how are you going to climb out? Help yourself climb out. So my focus, my passion is always on the mind body stuff, because that's what people can do when they have nothing left, you know. And you know, I've been there, and you got to be able to help yourself, and going to PT a couple of times a week is great. But if you're also not moving better and moving more at home and understanding how you're standing and brushing your teeth and how that affects your shoes, or just a whole bunch of things that we don't even realize how much they really impact us over time, that then also impact our ability to go to PT or to take a walk with our dogs. There's so many subtle little things that we can do, and that are easier than trying to tackle the big things sometimes.
I'm glad you said that's so important.
Hi, I'm sitting on the floor, Dr. Atwal. I don't have a desk. I sit on the floor. The floor is my desk.
Great. But your point is so important. That the psychological, mental, and even you could even say like spiritual health of someone is very is as important, if not more important, as the turning up with a physical therapist whenever it is. The education education on knowing what to do and how to do it as a key part of that. But also, I give and the people that come and see me, I actually give them some coping strategies for pain, for cognitive behavioral retraining, almost, if you will.
Right.
I've even talked to some patients when indicated on things like meditation and other things that might help them. And these are things that are actually do have evidence behind them.
Absolutely, and there are different types of meditation too. So I mean, So some are better than others.
Of course. So these things aren't kind of they're actually, there's actually a good evidence base to support their use in mainstream medicine.
Yeah, wholeheartely. I would love to be more. I would love to do more research on that, because it's actually less costly too.
Oh yeah,
and maybe more accessible.
If we can,
right? I mean, exactly. Like exactly. Exactly. So, doing a health education program on mind-body strategies for hypermobility and seeing what the outcome is a lot less costly than other things. And if we published it, I mean, how great would that be? So
sounds like a great idea.
I have that program. I did develop it. I wanted to do that's a whole other story, but I submitted an abstract for it. Basically, based on Dr. Frank Amano's experience at a program she did at NIH years ago. So
I'd love to see that.
Funding's always, nobody wants to fund wellness stuff, Dr. Atwal.
Oh, that's a shame.
So it is, we have a couple more good kind of just general questions. It is terrible eyesight. Like, I'm sorry, y'all. I do have my contacts in. I think it's about 7:50. Yeah. How are you doing on time, Dr. Atwal?
Yeah, we've got a few more minutes. Let's get a question.
Okay. All right. Can you touch on MTHFR?
Oh, yeah. All right. So yeah, there's a lot of problems with MTHFR, and when I say problems, I mean in education on what it is and what it isn't. And so I think it's important to understand the background. So methyl tetrahydrofolate reductase is an enzyme involved in folate metabolism, one of the enzymes. And in the past, before regular sequencing was available, people were looking for genetic influence factors for all sorts of things, cardiovascular disease and risk of miscarriage and all sorts of things. And this variant, a couple of variants in this gene kept coming up as different in a whole host of different things. And so a few papers were published with these associations, and then people started thinking they were associated. Only after, when larger scale sequencing was done and people realized actually these variants are present in some cases 40% plus of the population. These are population variants, population level variants that don't have any measurable change in these conditions. Then all that prior evidence had already been published. So the American College of Medical Genetics actually back in 2013 released a practice guideline showing that through this aggregate data, or this pulled in data from all of these sources and pulling it all together, realize actually there's really no evidence to show these variants are associated with all these conditions that in the past said they were associated with. And only if you have a true elevation in homocysteine that there could be potential problems. And so that was actually, believe it or not, that was 7 years ago. To this day, you'll go online, you'll type in MTHFR, and you'll find websites saying it's the reason for all of your problems. Now that's a hard message for people to hear, I'm sure, because they've put a lot of they're committed to that condition, so to speak. So I have to go through this process with people probably every week when I'm talking about it. And it's never easy, but it's important people know the truth.
People want. I mean, it's hard. I mean, it's hard because the research can really make you feel like that's might be it enough to help if I can help that or solve that or address that,
Yeah.
that might help a lot of my symptoms.
And
Maybe not take away things. It's hard.
And it gets worse when you there. I mean, I remember there was this doctor. Well, not doctor. It wasn't a medical doctor. It was a, I don't know what they didn't have a medical degree, but they called themselves doctor. Was testing people for MTHFR, putting them on a supplement, saying that because of this, you should take this supplement, and they only have it in their clinic. They're the only one that provides them that supplement, and it gets very let's say it gets very shady very quickly.
Yeah, it does. And it's hard when you're desperate for answers and you feel so terrible, and you've tried your typical things all the time, and it's tough. I mean, and the really tough part is when you have to really look at yourself in the mirror and be honest with yourself too, and be like, okay, what am I bringing to the table to also affect my spiral? I mean, I have to do this myself all the time. It's not a fun conversation to have, and say, okay, well, you're not doing the high intensity workouts that your body needs, to cope. And the fatigue I mentioned was a really big thing. Somebody actually mentioned that. Any tips on dealing with the fatigue for people that are really just struggling with the fatigue? And it's this.
So I think with there's there are physical strategies. So trying to maintain a level of physical conditioning, no matter, even if it's I try and tell people, just do something every day, even if it's just for 5 minutes, ideally 10 to 15. But even if it's just 5 minutes, do something.
That's my tagline on the back of our shirts, Dr. Atwal.
Really? That's great.
EDS, just 5 minutes.
Just 5. That's a great tagline. I love that.
Yeah, it was. That's what I on the back of EDS Wellness tank tops is hashtag just 5 minutes, because I would say the same thing.
So important. So important. So yeah, just can I use it? Just 5 minutes every day.
Go ahead. I'll send you a T-shirt.
Oh yeah, please do.
Because nobody else is wearing them, although.
I'll wear it. And then there's the mental health aspect to going back to that point, thinking why am I feeling like this, being aware of that feeling and thinking, okay, how do I, is this the feeling I want to be feeling, and if so, if not, then how do I change it? So there's a mental aspect that's very, very powerful as well, and not to be dismissed, and not and then avoidance of things that are going to make it worse. There's things that that are stressful to your body or stressful that you probably shouldn't be doing anyway. So cutting that out. And also, if you're going to be in a situation that is going to make you tired or make you fatigued because of it's a bit extra or not something you normally do, then putting some preemptive strategies in place to minimize that.
Yeah, and also recognizing where your body is at, meeting your body at where it is, whether it's deconditioned or just having a really bad day. That doesn't always have to be the hour of PT, the hour of exercise. Something's better than nothing.
Oh yeah, absolutely. Yeah.
Sometimes the best grace we can give is just continuing, even if it is for 5 minutes. I mean, that's a hard pill for me to swallow too. I got to be honest, it's tough, but that's why I started saying it, because sometimes we have to recognize that the caliber that we have, that we feel that we should be at, or is good enough, or is what we're supposed to be doing, isn't what is really meeting our body at where it is in order to get to that back up there. And that's hard.
Exactly. Yeah, you're right.
All right. So it is, I have there's one question here, Dr. Atwal, and I have a couple just fast ones before we go. I want to be mindful of your time.
Okay, yeah, go ahead.
It's harder for me to see. I apologize to anybody that's wrote longer questions. It's harder for me to read and also try to condense it so that I can ask it and know if it's appropriate for Dr. Atwal to be able to, not too personal, because this is not medical advice, and not to be construed as anything for you visiting your doctor. So I have to just please understand that I have to also look at questions, and if they're longer and they're more personal, that I have to be cautious of either how I ask it or to try to condense it so that we can also get to other questions. So I was asking about just the doctor is not recommending getting genetically tested, because the person doesn't necessarily meet all the criteria for hypermobile EDS, nor has the family history to kind of support it, but the family history is also limited in terms of what she really knows. So
yeah,
in the situations like that, where somebody doesn't meet, you know, all the criteria, doesn't necessarily know the medical history, but has other things like POTS and Chiari and things,
yeah,
is genetic
yeah.
testing something that's warranted there?
Yeah, so yeah, and to your point, it's obviously I'll speak in general terms without it's impossible to know the specifics, but you know, someone that has the gestalt or the kind of features of something, it's important to not dismiss it because you know you miss it by some minuscule cutoff. We don't know everything about all of these conditions. These criteria continue to evolve, continue to change. It's really important to see an expert in the condition that doesn't go on tick boxes on a piece of paper, but really understands the condition in and out. Criteria, these, you know, I'm presuming they're talking about the 2017 hypermobility criteria. These are very valuable, but these are for non-special. Really, for me, these are for non-specialists who aren't aware of the ins and outs of the condition, but through these tick boxes on this one piece of paper can go through through all of that and feel comfortable that they're diagnosing this condition. So it's allowing kind of non-specialists and other docs to feel empowered to diagnose. So at that point, make sure you're seeing someone who really genuinely is an expert in the condition, and if something doesn't feel right, get a second opinion.
Absolutely. Yeah, we can go elsewhere.
Yeah.
That's hard too. I mean,
that's hard. It's hard to know. Yeah, it's hard, but you know.
But you know your body. I always say we know our body's best.
Yeah, I've seen enough people that have been misdiagnosed and told they've got something else like fibromyalgia or something else, and they, you know, or there's nothing wrong with them. Go see a psychiatrist, or all sorts of crazy things patients are told. So if it really doesn't feel right to you, then you can
keep trying to find somebody. Yeah,
yes.
For sure. I think I take that for granted, probably because I didn't have parents that really helped me, so it was always up to me. So I kind of just kept going and fighting. But I now, in terms of like having my own kids and also recognizing teenagers where parents are kind of more involved and they do believe their kids, but they almost have to, you know, fight. But it also then creates a predicament that if you're kind of at the mercy of the doctor that you're seeing, especially if you're exhausted and you're just dying for somebody to help you, and it's very frustrating. But you don't necessarily have the experience of just, you know, keep going. So, but yeah, I agree. Keep going. That's pretty much it, other than just a couple of final ones. Somebody said, can you talk about hypermobile EDS and memory issues?
Yeah, so it's common that people have some degree of cognitive difficulties, like you know, forgetful or difficulty concentrating, that kind of thing. And it's very simple. It comes down to, if you're tired all the time, if you're in pain all the time, try and set you know, an important exam, or you know, concentrate on some hard problem when you're you know, tired and in pain. It's impossible, right? So that's what if someone's like that all the time, then that's where their memory issues and, you know, forgetful and all of these things come in, and there's no intrinsic problem in the brain, right? But it's the brain is connected to the rest of the body, and the rest of the body is suffering, then the brain's going to suffer too. So and so that it's all kind of connected. That's the way I try to explain it to people.
Yeah, I mean, or if you've migraines, I mean, you know,
exactly.
in your brain, or inflammation. I mean, or kids that stress you the heck out, and they are doing virtual school. That's enough.
That's another one.
Oh my gosh. There is there's actually, it's 8:05. Might say 8:10. There's actually another, if you're willing, another actually great question that's more along the lines of your expertise that I think many of us might be interested in. It's about if you have a condition that seems to be acquired and dramatically impacts metabolism and processing, forgive my eyesight, I have to go so close, processing that can be picked up. So a condition that can be acquired and it dramatically impacts metabolism and processing, can that be picked up by genetic testing? And if so, how can somebody go ahead and go down that path of trying to figure that out?
It's quite it's an interesting, quite general in that. So excuse me, something's purely acquired. It suggests there's no genetic component. So you know what something, let's say, excuse me a second.
No.
I don't have any water here. Oh, okay.
I was like, I have my water here. I'm like,
it's all good. What's something that's, just to take a step back, something that's purely acquired? You know, falling off your bicycle and hurting your elbow or something, right? There's no genetic. Well, you could argue there is, but there's no genetic component and that's influencing that. So there's nothing to test for genetically. It's a pure acquired condition. Now, there's conditions that have an acquired component and a genetic component. For example, heart disease or coronary artery disease, right? So there's a genetic problem, a genetic component that if heart disease runs in your family, you're more likely to have it. But also there's lifestyle factors, you know, obviously age, obviously smoking and diet, exercise, all of that influence it. So this is something that has both elements, and it's called complex disease. It's called complex disease. So there's genetic factors and non-genetic factors. For those conditions, depending on what it is, there could be a genetic component to it that could be unmasked to show that yes, because of this, you're getting more of this problem than if you didn't have it. You know, I don't know what specifics there are there. Obviously, probably best we don't get into specifics, but to answer your question, yes, there are conditions that have a genetic component that have also an acquired component to them. That the genetic.
Would that also be something like not lymphedema, but lymphedema, that I know is a comorbid condition to EDS, but it's a fat metabolism condition? Is that correct? Is that something that can be tested for genetically? I'm just curious.
I don't lymphedema.
Not lymphedema. No, it's lymphedema.
Lipedema. Yeah. So lipedema.
Yeah.
Lipedema. Okay. Yeah. So the thing that there's I'm not sure if I haven't looked at it in a few months, but I have seen a few people with lipedema. Doesn't seem to be the kind of like hypermobile EDS. Doesn't seem to be like there's a gene that we found for that condition. I'm not saying it's not genetic or it doesn't have a genetic component, but it doesn't seem like we're able to find much at this stage. Much genetics that influences it. Not to say there isn't any, but you know, that's where we are with current research.
Yeah. It's interesting to the person's point when she asked about the metabolism condition and
very
interesting. Also. So, all right. Well, I appreciate your time. I don't want to take too much of it.
Great.
And I appreciate you staying longer. Everybody else does. I think we kind of got through, you know, the questions I had and the, you know, basic questions that were on there. Any final thoughts that you have? One thing you wish EDS patients knew, or those that think that they have EDS that you wish they understood?
One final thing.
Give them? Final thoughts.
I would say the final thought would be don't get disheartened on trying to get answers. Often people will see, unfortunately, many different doctors before they actually find someone that understands the condition and even confirms it for them. And then second, don't fall for well, there's no point in getting it diagnosed because there's nothing we can do for it or no cure. There's lots that can be done. Just because there's no pill that you can take that suddenly everything's cured doesn't mean there's nothing that can be done. There's plenty that can be done.
Absolutely.
All right, thank you.
Well, thank you so much for your time. Thank you, everybody. We're going to go ahead and end the Facebook. Dr. Atwal, I make sure everybody has your contact information for your clinic if they're interested in learning more about your services.
Great.
Thank you so much,
Thank
everybody.
You. Happy to do it again. I'll talk to you later.